Hi everyone, it's Penny Corkum. I'm here to do a webinar or a Facebook Live event to recognize World Sleep Day. So around the world, we're celebrating and recognizing the importance of sleep. And I'm sure if you're joining me, then you also recognize the importance of sleep as well. So this is my first time doing this, so please bear with me as I try to work through it. But I'm here today to talk about sleep in children with neurodevelopmental disorders, and we're going to focus on the impact and on intervention. And as I said, I'm a faculty member here at Dalhousie University in Halifax, Nova Scotia, and I'm also a child psychologist, and the area of my research is in children's sleep and children's mental health problems. And the research in neurodevelopmental disorders is funded through Kids Brain Health Network, and you can see the logo up here. And if you're not familiar with this National Center of Excellence, you should pop onto their website and learn a little more about them. So the way we're going to do this today is I'm going to give a presentation, and you can see behind me are my slides. Unfortunately, Facebook doesn't allow to toggle between the person speaking and the slides, so we decided to do it this way. I hope that it works for you. And so what I wanted to cover today was the sleep basics. So a little bit about sleep so you know more about it, how sleep might differ in children with neurodevelopmental disorders, as well as the general and specific sleep intervention strategies. And sorry, I'm clicking the button down here, so if I look down, that's what I'm doing. So the scientific study of sleep really is fairly new. Not until probably the 1950s did we think that anything interesting was happening in sleep. We actually thought the brain was sort of turned off and not very interesting, so nobody studied it. But in the 1950s, rapid eye movement sleep was discovered, so that dreaming sleep, and lots of people became interested in dreaming sleep, and we started to study sleep. And we realized that, wow, lots of things are happening during sleep. The brain is very active, and it's sometimes even as active as when we're awake. So lots to explore and discover about sleep. So a little bit about sleep. Sleep's divided into two broad categories, REM sleep and non-REM sleep. So REM sleep is about a quarter of our night is spent in REM sleep, and this is our dreaming sleep. There are high levels of cortical activity, so our brain is really awake, but our body is paralyzed. This is a good thing, so that we're not acting out our dreams. You might see, if someone's in REM sleep, you would see some eye movements happening beneath their eyelids, so some darting back and forth. And this occurs, REM sleep occurs about every hour to hour and a half. And we think that REM sleep is really important for learning and for memory. Non-REM sleep accounts for the other 2/3 or 3/4 of our sleep. And this is a more deep sleep that we think is more about restoration of our body functions. In this stage of sleep, we can still move our body. So for example, if we're sleepwalking, we would be in a non-REM sleep stage. If you want to think about the difference in terms of sleep disorders, a nightmare would happen during REM sleep. So we would not act that out, our body's paralyzed. A night terror would happen during non-REM sleep. So we may still move our body but be in a deep sleep. These two stages of sleep kind of go together in cycles across the night. You'll see that here. So first we go into some deep non-REM sleep. Non-REM sleep, there's different stages, and it's deeper and deeper as we go. You'll see most of the non-REM sleep, or the light colored gray, is early in the night. And most of the REM sleep, the darker color, happens more early in the morning or late at night into the morning. And you see that there's cycles. After each of these cycles, there's a little arousal that happens where we sort of come a little more alert to check the environment to see if everything is still okay. No tigers are chasing us, for example. So this is an adaptive mechanism in our earlier years or earlier days, but now it can lead to some problems. So when babies wake up, which is normal, young children, everybody wakes up through the night to check in, but some children don't have the ability to self-soothe. And so that means that they don't fall back to sleep. They call out to their parent or they cry. So it's not that they're waking up that's a problem, it is that they're not falling back to sleep. That's a challenge. So what makes us sleepy? There's really two processes. The first is called a homeostatic or sleep pressure. This is pretty obvious. The longer you're awake, the more tired you're going to be. And the sleep pressure regulates the length and depth of our sleep. So if I stay up long time, I'm going to be tired, and you would think I'd fall asleep, but that doesn't always happen that way, because there's a second process called circadian process or circadian clock. And this regulates the timing and the duration of our sleep. And what we have to do through a day, we have maximum times that we're alert and maximum times when we're kind of groggy and not very, more likely to fall asleep. What we have to do is line these two things up. So for example, if you're a night shift worker and you've worked for 12 hours and you get off work, say it's at 7 or 8 in the morning, and you're really tired because there's a lot of sleep pressure that's been built up, you would think that you could go home and go to sleep. But you know that's not the case. Many people have trouble falling asleep even though they're really tired. And that's because their circadian clock is now in a phase that's maximally awake or alert. So it makes it really hard for people to fall asleep. So when we're working with children, we're trying to line these two processes up so that there's lots of sleep pressure and they're at the right circadian phase to fall asleep. So we also know sleep changes with age. So this graph here shows this. So the dark parts of the stacked bars is REM sleep, and this is non-REM sleep. And this is total sleep. So you'll see that over the years, we get less and less sleep. We also get less and less REM sleep as we get older. And non-REM sleep declines a little bit as we get older, but not to the same degree as REM sleep declines. So a question might be, how much sleep does my child need? And this is a difficult question because there's a lot of individual variability. And so every child or every person is unique, and their sleep needs may be unique as well. There's a couple of guidelines we can use. So the first one here is from the National Sleep Foundation. And what you see here in the dark blue is the recommended number of hours by age grouping. And so you'll see for a toddler, it's between 11 and 14 hours a day, preschooler 10 to 13, school age 9 to 11, and a teenager 8 to 10. The lighter blue is the area of kind of potential sleep needs, but we really recommend following the dark blue. There's another guideline that recently came out through Canada's participation, and this is the first 24-hour guideline ever made in the world that looks at needs for not only sleep, but movement and trying to reduce sedentary activity. So both of those are really useful guidelines. So how do we figure out for your child? These are guidelines, but they're for average child. What about your own child? So what we recommend is during a vacation or a time when the child can sleep as much as they want, to let them sleep in and see kind of how much sleep they need to function during the day optimally. So happy, not sluggish, maybe not irritable, and then we can use that as the amount of time that we think the child needs and work towards that goal. So there's a lot of children who are not getting the right amount of sleep. Part of this is lifestyle factors. We live in a 24-hour a day world. We can log on to Facebook at any time and be entertained. We can turn TV on at any time. We can talk to different people around the world, shop around the world. So it's really hard sometimes to prioritize that sleep. And so definitely this impacts our amount of sleep we're getting. And in fact, all of us are getting about 1 hour less a night than we were at about 100 years ago. And you might think, well, 100 hours doesn't sound like a whole lot, but in fact, we've shown that 1 hour of less sleep can actually have a big impact on us during the daytime. We can be more irritable, we can be more sluggish, maybe our memory is not as good or our thinking is not as clear. So that 1 hour can really make a difference. So most of us are already starting a bit sleep deprived. And then if we have a sleep disorder on top of that, it can compound the effects of insufficient sleep. So about 25% or a quarter of typically developing children, so by this I mean children without mental health problems or children without physical health problems, so a quarter of them have sleep problems or sleep disorders. However, children with neurodevelopmental disorders, the vast majority of these children would have sleep problems. We kind of estimate about 75% or more. So most children are struggling to sleep well when they have a neurodevelopmental disorder, and parents of these children are trying hard to get their children to get a good night's sleep. The most common sleep disorder is insomnia. And insomnia just means difficulties falling asleep, staying asleep, or waking too early in the morning. There has to be daytime consequences, and so you have to be feeling tired or at least behaving in a way that would indicate that you're tired. You have to have an adequate opportunity for sleep, and this problem has to be frequent, at least 3 times a week, and chronic, at least 3 months or more. And it can't be explained by other sleep disorders, so say, for example, sleep apnea or other medical or mental health disorders. So what are the consequences of sleep problems and sleep disorders? For the child, they can be pretty severe and can really make the developmental process quite challenging. So we know that it can impact cognitive ability and learning. So these children who sleep poorly or sleep not enough have lower grades at school, poorer attention, and poorer memory. They also can have more social, emotional, and behavioral challenges. So increased emotionality, so more irritability, more behavioral challenges, and lower self-esteem. And there can also be physical consequences. So we know in the research that short sleep is related to health outcomes such as obesity and other metabolic disorders, as well as being related or linked to, or at least correlated with motor vehicle accidents and other kinds of accidents. So if you're tired, you're going to be more likely to, make errors in your judgment. But it's not only just the child that's impacted by these sleep problems. Their family is also impacted. So sleepy children have sleepy parents, and then parents have the same sort of daytime consequences of not sleeping enough. It can also impact the school and the community more broadly speaking. So for example, if children are tired in school, they may not be as receptive to the learning environment. So let's talk for a few minutes about sleep in children with neurodevelopmental disorders. So as I mentioned already, children with neurodevelopmental disorders are much more likely to have sleep problems, and insomnia is a big part of that. So we're focusing on insomnia today. Perhaps we'll do another Facebook Live session, if this works, on different sleep problems in kids with neurodevelopmental disorders. You could always write a comment if you're interested in any particular topics. We'd be happy to see what we can do about that. So they're much more likely to have sleep problems. They're much more likely to have insomnia. And the problems associated with sleep problems, so that I mentioned earlier, differences in cognitive ability and learning, emotional regulation, behavioral regulation, these children often have these problems to start with. So sleep compounds that and makes it even more problematic for these children. It also can interfere with treatment. And so if a child's tired and they're getting treatment for some other component of their neurodevelopmental disorder, so for example, some individualized education program, and they're tired and they're not really able to learn because they're so tired. So sleeping, kind of helping children sleep, can improve the other treatments as well. We also know that children's sleep problems, children who have neurodevelopmental disorders and sleep problems, these tend to be more persistent than in typically developing healthy children. So they don't kind of remit without some intervention. So what do we do about this? So I don't think you can see this very well, because, oh, yeah, you can. So we think of it as a triangle, and at the bottom, this is where this is where we start. These are the least invasive types of interventions that don't have any side effects. So first is psychoeducation, so teaching about sleep, like what we're doing right now, and helping people understand how sleep works. Then implementing healthy sleep practices, again, to facilitate sleep. And if that doesn't work, moving on to behavioral strategies, so very specific behavioral strategies. And kind of as a last resort, medication. And we shouldn't jump these ones up to medication. We should really go through this and make sure that we've implemented these before we try medication. So for children with neurodevelopmental disorders, we might need to add a few extra components here. So first, we want to address other concerns. So for example, if a child had reflux, We might want to address that before addressing the sleep problems. We might have to adapt both the healthy sleep practices and the behavioral strategies for the child with neurodevelopmental disorders. And this adaptation might have to be specific to that particular neurodevelopmental disorder. Children with NDD are more likely to need more intensive supports to help address their sleep problems. And often will end up using medication, not everyone, and we definitely can make a big difference using the behavioral strategies, but for some children we may need to add melatonin or a prescription medication, but again, not until we've tried all of these other ones, and we can make a lot of progress using these. So I thought we'd go through each of the components and talk briefly about those. So the first is psychoeducation. So that's exactly what we're doing now. Talk about what is sleep? Why is it important? What are the different stages of sleep? What about sleep associations, being able to link bed and sleep in a child's mind so that they fall asleep when they're in bed? What happens if we don't get enough sleep? What are some other common sleep problems in children with neurodevelopmental disorders that we might need to address, such as obstructive sleep apnea? What about effects of medication on sleep? So for children, say, for example, with ADHD, might be taking stimulant medications that can interfere with sleep. And also dealing with safety issues for these children, so if they might leave their room. In terms of healthy sleep practices, we've came up in our research lab with the ABCs of sleeping, and this just reminds us of all the important components of healthy sleep. So first of all, age-appropriate bedtime, wake times, and naps. So we need to make sure the child's going to bed at the correct time. We say before 9 p.m. There's some research that shows that this is pretty optimal for children, and that's consistent from weekdays to weekends, and that wake time is also consistent in terms of scheduling and the routine that the child follows. This has to be consistent, as I said, between weekdays and weekends. We need to have really good, strong schedules and routines in place to help children wind down and relax before falling asleep. You need to be relaxed to go to sleep, so you can't be playing video games right up to that moment, or else you won't be able to sleep. The location, we need to think about that. They need to have a dark, cool room without a lot of distractions or a lot of noise in order to sleep. Can't be too warm or too cold. No electronics in the bedroom or before bed. This is really critically important. Hard to do, I appreciate that, but also really important. So research is showing again and again the link between using screens and having difficulty sleeping within that period, within kind of the wind down period of sleep. So for children, we try to say about an hour before bedtime not to engage in these stimulating activities. And why is this? Well, it's partly because they're stimulating and get kids, wound up, and that's hard to sleep when you're in that kind of aroused level. But also, it's because of the light that's emitted from them. So it's kind of a two components that are interfering with sleep. So it's best to keep those out of the bedroom. Exercise and diet. So you have to have a healthy kind of day in order to fall asleep at night. But you don't want to do these too close to bedtime because they can interfere with sleep. So having a large meal before bedtime is not going to be conducive to sleep. Positivity and relaxation. You want the bedtime routine and the whole day to be positive, and definitely as you're leading into bedtime for it to be more relaxing and calming. Independence when falling asleep is also really important, and so the child has to be able to self-soothe to go to sleep on their own. That way when they wake up at night, remember when I talked about those little arousals, they can use that self-soothing to go back to sleep instead of signaling or calling out to their parent. And if you do all of this, and you meet the needs during the day, then typically children will end up having a good sleep, and adults too. So in terms of the third level of interventions is behavioral strategies, and I'm just going to talk about some of the key ones for children. So the first is extinction. Now this is kind of the cry it out method, and a lot of people may have some difficulties with this method. It's not easy to watch your child or not watch or hear your child, fussing and being really upset. So we often recommend modifications of the extinction method called graduated extinction. And basically for this, you follow your bedtime routine and your bedtime and your wake time schedule, and you put the child to bed when they're drowsy but not asleep. So they have to be awake but drowsy when they go to bed. And you Set a schedule. So you're only going to check on the child based on your schedule, not on how much they're crying. So you're trying to not reinforce the crying. So you might start with every 5 minutes, I'm going to check my child, and then move it to every 10 minutes, every 15 minutes, and you're going to gradually extinguish that behavior. Once a child falls asleep on their own at bedtime, then usually they can use those self-soothing skills to help themselves fall asleep in the middle of the night. Sometimes you might have to add in a different component, but typically this approach can be quite effective. Again, some parents find this approach a little bit difficult and hard to do, and if that's the case, we often recommend what's called graduated extinction with parents present. And so what we do is start with the parent in a position that the child's comfortable with, so it might be sitting next to the bed with their hand on their child's shoulder, say, and then over time we move the parent and the chair further and further away from the child until the parent is outside the child's door and the child's falling asleep on their own. So those two approaches are really helpful if the child has difficulty falling asleep independently. If a child can fall asleep independently but is having difficulties actually falling to sleep, so they're laying there for a long time not being able to fall asleep, we follow something called a bedtime fading routine. Basically what this means is that we put the child to bed at a time that is they're likely to fall asleep, so about a half hour when they usually would fall asleep, and that helps them develop that paired association between sleep and the bed. If they do this and they fall asleep quickly, then we usually reinforce that, and then we back up in 15-minute increments each night until we hit the target bedtime. If they can't fall asleep within that, say, 20-minute time period, then they have to come out of their bed and do a kind of low-key calming activity and then try again. So it's not a punishment, it's just to let that sleep pressure build back up so that the child is likely to fall asleep. This can be a really effective method. It is pretty intensive, so parents, often we recommend that parents don't do this if they have to be at work early the next morning, but maybe again on a holiday to try out these strategies. For all of these strategies, we like to use positive reinforcement, so rewarding the child for being successful and to try and follow the rules and routines around sleep. So we might have a sticker program, for example, like this. We also try to use relaxation strategies. Many children have a hard time calming down and self-soothing, so this will teach them those skills. So deep breathing, for example, or progressive muscle relaxation, or guided imagery, or some of the strategies. This may take a long time to teach the child these skills, and children with neurodevelopmental disorders may take a little longer to learn these skills, but I think we can teach these over time, and they can be really useful for sleep, but also for daytime functioning as well. So more broadly speaking, what do we have to think about when we think of sleep strategies for children with neurodevelopmental disorders? First of all, we need to adapt the language in our communication to the child's level so that they understand and follow what we're asking. We want to particularly pay attention to any resistance to change. So some children find it hard to change routines, and we have to be mindful of that and prepare the child for that. We wanted to use a step-by-step approach, and so that's very systematic. We want to use rewards that are immediate and very salient for the child, so they're really reinforcing to that child. It may take longer. We might have to stick at each of those stages a little longer in order for it to work. Using visual charts can often be really effective, so you might have a series of pictures of the bedtime routine, for example. Or even social stories, where they read stories about the bedtime routine, and a child falling asleep can help reinforce some of these skills. Like I mentioned earlier, medications are at the very top level, and we try not to use these, and I'm a psychologist, so I'm not a physician, so I'm not going to answer many questions about this, but I can only tell you what the research says, which is there are no approved medications for sleep for children. And so when we use, and when medications are used for children to help them sleep, this is off-label. These are not intended for that purpose with that age range, at least. So we have to be careful when we use these, and there's definitely situations where children may need medication to help them fall asleep, but we want to make sure we try everything else first. Many parents will have tried melatonin with their child, and so this is a naturally occurring hormone. It's called the hormone of darkness. So basically, it becomes elevated in order to help us fall asleep. And so sometimes taking this medication can help children fall asleep, or it can help with the circadian rhythm as well. The research has shown it's fairly safe, but there can be some mild side effects. Often a child might habituate to this and an increased level might be needed. And so really probably best to work with your family physician to ensure that the child's taking the right dose at the right time. And there's a really great guideline on the Canadian Pediatric Society website that you may want to read about this. So in terms of wrapping up, just a few take-home points. So you saw that sleep changes with age and is highly individual, and is a significant problem for children with neurodevelopmental disorders. We not only need good sleep quantity, so we need a good sleep duration, but the quality of sleep needs to be good. We can't be waking up a lot during the night. So we need to focus on both quality and quantity of sleep. Good sleep habits are really critical and lay the foundation for good sleep and for other sleep interventions. So we have to start there for sure. The ABCs of sleeping is a great way to remember all the parts of a good sleep and healthy sleep habits. And we can treat these sleep problems in children with neurodevelopmental disorders, and we can treat them with behavioral strategies. So we don't always have to go to the medication. So I'm going to take this opportunity to talk a little bit about a research opportunity. And I had started the presentation by talking a bit about funding from Kids Brain Health Network, and they're funding a study that we're doing called Better Nights, Better Days for children with neurodevelopmental disorders. And the website is up here. If you can't see it, it says ndd.betternightsbetterdays, all like one big long word, .ca. And this is a program that we're almost have finished developing and are going to launch very soon over the next few months. And it's a behavioral program, so there's no medication involved. It's using all those strategies we talked about to help children sleep better. So the parents would get this information online, follow the program, and then we evaluate the outcome and see whether it worked for these children. In terms of this particular research project, we're going to be asking parents of children with ADHD, autism spectrum disorder, cerebral palsy, and fetal alcohol spectrum disorder to participate. And the intervention's, I think, really cool. So it's all the things we talked about, and it's general, but also specific to the child's diagnostic kind of grouping. And so there's both general strategies as well as specific strategies. And we're hoping to launch that kind of late spring, early summer. So you can go to our website and you can look there and see if you're interested. And you can also leave your email address and we can let you know when it's being launched. Here are a few resources. You might not be able to see this, so I'll just read them out. The first is the Canadian Sleep Society, has a lot of great information. Kids Sleep, so KIDZZZ Sleep, and this has some nice information for children. The National Sleep Foundation, SleepNet, Sleep for Kids, and then there's the Autism Speaks Sleep Toolkit, and this is a really comprehensive kind of manual or book about how to work with children with autism to help them sleep better. So with that, I'm going to leave this up and I'm going to open up for Q&A. Now, I haven't done this before, so you're going to have to bear with me, and I'm going to have to come in closer, sorry, but I can't read the questions, so I have to figure out how this works. So, sorry about that. Okay, I'm going to start here. So what age is graduated extinction recommended? Yeah, so we would say not in the first year, because really in the first year, you have to meet their needs and their circadian rhythms are being established. And so it's good to have sleep routines and to have bedtimes and wake times, but we wouldn't usually use the graduated extinction until after 1 year of age. If there's other questions, feel free to write them in the comment box there, I guess. I'm not quite sure how it works on your end. Well, I'm scared to click the escape, it might go away. Okay, so I'm gonna have to try that. Okay, here we go. So my son was blessed to participate in a pilot project for the study. Oh, great. Thank you. It was an incredible experience for our family. Well, thank you so much for participating. We really appreciate that. So as Janine was saying, we actually had a group of families, about 30, try it out and give us feedback. And what we're doing right now is taking that feedback and modifying the intervention so that even works better, hopefully. But that's really great to hear that it was helpful. And, I think a lot of parents say, you knew some of these strategies anyways, but just having the support of the structure and what to do when was really helpful. So Amanda says, let's see, her child has autism and on and off some sleep problems. Yeah, so night wakings that don't, night wakings that last a long time, and that's common. It's also common that melatonin at one point worked and doesn't seem to work again. Sometimes trying it again after a break will help, but definitely a lot of parents report that. So again, it's that self-soothing, and I know it's really hard to teach this to children, especially a child with severe autism. But what it sounds like is happening is one of those arousals that I talked about after a sleep cycle. So they wake up during that and they're not able to fall back to sleep. And so working on what to do in that situation, how to self-soothe. I don't know your child well, so I can't give specifics, but that's where I would start to try to work on that. Obviously, safety is so important because you would be sleeping, so we often recommend on the door something that would alert you if your child left the bedroom, whether that's an alarm or a bell on the door, just to make sure that they're safe. That has to be number one. Okay, great. So the question is future studies on genetic disorders. Yeah, I think that's fantastic. So the way we tried to develop Better Nights, Better Days was to be able to modify it for children with a lot of different challenges. And so some of the strategies are strategies that are general, that we have to do for all children, but there's certain things that we do differently depending on the disorder. And so what I'd like to see is other researchers who have expertise in particular disorders, for example, epilepsy or genetic disorder, like Down syndrome, that they would come and we could work together and develop a program that's a modification of Better Nights, Better Days that would work for that particular group of children. So I'm open to those collaborations, and I think in the future I would love to see that happening, and I hope that it will. Is there other questions? I'll talk. Oh, okay. Okay, great. Okay, thanks again, Janine. So her child had a range of challenges, and the program worked for him. And this is one of the questions I think is really an important question, is how much do we have to modify to make it effective for a group of kids? So one of the first things we do is try this one out and see what we have to modify. And maybe for some kids we wouldn't have to modify a lot, which would be really exciting. I'll tell just a little bit of history while I'm waiting to see if there's any other questions. So we first developed Better Nights, Better Days through a grant from the Canadian Institute for Health Research, and we are right now doing randomized control trial across Canada with typically developing children. By that I just mean that they don't have mental health disorders or physical health disorders. And so we have over 500 families from across Canada participating and trying out the program, giving us feedback about their experience, but also how their child's child is sleeping, and we're wrapping that up this summer, and so we'll be able to give the results of that. But again, we've heard some really positive feedback so far, so hopefully that will continue. And then, like I said, we're going to next launch it for children with neurodevelopmental disorders, and then we'll see where we go from there. So I don't see any more questions, so I think with that, I will sign off and thank everybody who's joined for joining in. I know that it's sort of the middle of the day for some people. For most people in Canada, it would be, and I really do appreciate you taking the time out of your busy schedules and coming to listen to this. We are going to post this live or as a video link onto the website, so if you think someone else could benefit from the information, you can send them to our website. And I think that's it. So thank you very much, and I hope everybody has a great sleep tonight, and now that you've learned all these skills. Thank you. Bye-bye. I might not be able to go, but